let's move on to another combination that received recent FDA approval in the metastatic setting. Let's talk a bit about Neratinib and Capecitabine in metastatic breast cancer. What is it? What's Neratinib? How does it differ from the other targeted therapies?
Neratinib is a orally bioavailable dual, actually pan HER receptor kinase inhibitor. So it blocks EGF receptor as well as HER2 and also HER4. HER3 lacks a kinase active domain in the carboxy terminus of that protein, so it doesn't hit HER3 per se. This agent has been tested in patients with HER2 mutations in the kinase domain, has been shown to have activity in that setting, particularly when combined with anti-estrogens such as fulvestrant. And this combination of Neratinib in combination with Capecitabine was put to the test head-to-head against Lapatinib plus Capecitabine, which was approved by the FDA many years ago. And this head-to-head trial was called the NALA trial, N-A-L-A. It was presented first at ASCO in 2019. And in that analysis, the difference between the two arms in terms of the PFS was about 2.2 months. Oddly, in that analysis, because the proportional hazard assumption did not hold, the separation between the curves didn't occur until roughly after about 6 months. So the statistical analysis plan for that trial pre-specified that a restricted mean survival analysis at 24 months would be performed. And in this pre-specified analysis, the mean PFS for patients on the Neratinib plus Capecitabine arm was 8.8 months, and the mean PFS for patients treated with Lapatinib Capecitabine was 6.6 months, and that met statistical confidence. The FDA has granted approval for Neratinib in combination with Capecitabine for HER2 positive metastatic breast cancer patients who have received 2 or more prior anti-HER2 based regimens in the metastatic setting. It's of note that when you use this combination, the drugs are to be taken orally once a day with food. The Capecitabine is given on a 14-day on, 7-day off cycle, a 21-day cycle, while the Neratinib is given continuously. Now, since Neratinib blocks EGF receptor as well as HER2, it is associated with EGFR kinase inhibition side effects, for example, diarrhea, particularly diarrhea. But it also can cause stomach upset, such as nausea, vomiting, anorexia, constipation, fatigue, weight loss, dizziness, back pain, arthralgia, and other troublesome side effects. It's of note that concomitant use with proton pump inhibitors is discouraged with this regimen. So patients requiring gastric acid reducing agents are to use a H2 receptor antagonist, but even then separated by at least 3 hours or so from the Neratinib administration. And then also remember, Neratinib is a CYP3A4 metabolized drug, so you're to avoid strong CYP3A4 inhibitors. Because of the potential for this drug combination to cause diarrhea, it's required to use a high-dose loperamide prophylaxis starting at 12 milligrams per day for the first couple of weeks, then 4 milligrams twice a day from day 15 all the way to 56 and as needed thereafter. So this can be a quite toxic regimen. There was no OS benefit, 21 versus 18.7 months, and no statistically significant difference in response rate, about 33% versus about 27% for the control arm. Interestingly, the TBCRC have presented data on this regimen prior to the pivotal NALA trial, and they noted some CNS responses. So in about 49% of those patients without prior Lapatinib exposure, they saw objective responses, and about a third, even with prior Lapatinib exposure, had response to this regimen, with median survivals in the range of 13 to 15 months, respectively. So this regimen is available technically in as much as it's approved by the FDA, but in my opinion, given its challenging toxicities, I would argue that it has been trumped by the tucatinib HER2 climb regimen, which is tucatinib in combination with capecitabine and trastuzumab. So I don't currently use neratinib in the late stage setting for HER2 positive metastatic disease because I don't think the therapeutic index is there anymore as compared to some of these more recently approved approaches.
I mean, based on the control trial, which was in the extended adjuvant setting, our group is actually also taken to starting cholesterol with the loperamide as we initiate the drug. Seems to really help control the diarrhea early on, and you can quickly get it off after a few cycles as you're tapering the loperamide. So while we learned how to help our patients manage the most significant side effect, I would agree with you that while neratinib has a role, it has some activity in the brain. It actually, FDA gave it orphan drug status for HER2 positive brain mets based on that TBCRC 022 trial that you described. But I do think that based on the side effect profile that tucatinib probably wins out here, although the two haven't been head-to-head compared in terms of efficacy.
Julie, have you ever used there was a cohort 5 in the control trial, which was a gradual escalation of the neratinib dose, first starting at about 120 milligrams a day. Have you ever used that either in the metastatic setting or in the extended adjuvant setting?
I've used it a couple times in the metastatic setting when I've had frail patients who have had a lot of treatment, and I just wanted to slowly ease them into this. Have you had much experience with it?
Yeah, I have tried it a few times since that cohort 5 was presented at a poster session. I forget which meeting, but I think it was about a year or so ago. And it does seem to help. You know, most of the diarrhea from neratinib happens in the first 2 to 3 months. And consequently, if you can just gradually escalate the dose during that interval, you can generally get by with it, albeit still with PRN, loperamide, and or cholesterol, as you rightly point out.